Good morning, everybody.
Good morning.
So we're going to start the second day with the case of a 43-year-old man who has recurrent attacks of alcoholic pancreatitis since 2009. In 2011, he had an attack with pancreatic duct rupture and a pancreatic fluid collection required EUS-guided cystogastrostomy. He since then has developed a disconnected duct syndrome with dilation of his corporal-caudal pancreatic duct and daily pain. He had a celiac plexus block in 2012 with limited effect on the pain, and since then he has daily pain requiring a morphine. We can see the MRCP, which shows the disconnected duct syndrome with a dilation of the corporal-caudal segment, and he also has splenic vein thrombosis. So he's scheduled today for EUS-guided pancreatico-gastrostomy, and we can join Marc Giovannini for the procedure.
Thank you. Thank you. Yes, okay. Marc and Dr. De Vier, we see you. And good morning.
So if we see us, it's perfect. Okay. We just started the exam. If you have the EUS image, you will see that Marc already located the pancreatic duct.
Yes, this is the body, the junction body tail of the pancreas, and here you have the duct dilated here, and you see this duct, the size is around 7 millimeters. This is the limit, and for the pancreatico-gastrostomy, it's more than 5 millimeters. We are, and I will try to target this duct, maybe here, because I try to find the closer position to the wall, and you see here the distance between the duct and the wall is a little bit far away, and I will try to find the best position. Maybe it's here, and I will target the duct with the 19 gauge needle.
So just
So Marc, the
different step is the first to obtain a pancreatogram, after to try to insert a wire deep as possible in the duct, to create the fistula using the cystostorm, and to leave in place a plastic stent, a straight plastic stent of 7 or 5 French, and this is the.
So usually what we do, Marc, when we do a pancreatico-gastrostomy, we place first a small stent.
Yes.
For 1 month, and then when the fistula has been created, we go back in and we replace it by 1 or 2 stents side by side, because
I do the same.
So you are using a pentascope and a Cook 19 gauge needle?
Yes. And
the preference for this class standard needle over the access needle in this particular case?
Yes, because it's, as you see, it's quite far away, the duct, and it's not easy to, and early in the morning like this, to
you want me to hold the scope, or?
Yes, maybe if you can maintain the scope in this position, will be great. Adjust the length. This is much better. And yes.
Okay. Sami, if we can have the fluoroscopy.
I will try to see if the. I think the needle is a little bit too.
Attends, je dois lâcher parce que Sami m'a. If you want me to go on the other side, I can do that. I think you're wearing now.
I'm not sure. I'm not sure that. Yes. Yes, I'm in probably. But yes, yes, I think I'm in. Maybe it's it's good to aspirate first to inject because if I'm not in yes, what is it? Oh, this is not very good, huh?
No, but it may be juice with a little bit of blood.
I think I'm a little bit too deep in the...
This is pancreatic juice. Huh?
This is pancreatic juice?
Yes, with blood in the
Yes,
inside.
now I'm in. Now I'm in. Okay. You can inject the contrast now.
So then we ask Sami to make a magnification. You should have the fluoroscopy image and the US image. I think that both would be nice to see.
It's difficult? No. It's vascular?
Yes.
Yeah?
No, no, no.
Right. This is good. This is okay. This is okay. This is the duct.
This is the duct, yes.
Okay. We are. Don't inject more, huh?
But then we
There
have
is
a leak
also some
for
vascular
vascular.
image, huh?
Yes, yes, but this is not a big problem. This will stop probably.
Oh no.
No.
You are in the leak? Huh?
Yes. Probably if you come back a little bit,
Maybe I can change
you are too deep with the
needle, no?
needle. Yes, if
I
you
will
can pull
remove
back a little bit.
Okay, like this.
No, no.
Mais tu peux mettre l'injection en dessous, s'il te plaît. Mettre une nerve en dessous. Écoute, c'est comme ça, on ne va pas essayer.
Ah, yeah, this is much better, no? This is the stenosis.
Mettre une image.
This is the stenosis.
So we will just double check the picture there. You see that this is always important to get to keep the initial injection image. So we might be in the pancreatic duct there, but
No?
the problem is that we should come back inside the duct.
I'm too close to the stenosis, probably. I should change the puncturing tract to... You are in the stenosis.
So you're trying to make a loop with the guide wire and come back?
Yes, yes, because we have no chance to pass this stricture. Huh? This is a complete stop.
Yes.
But then we are in a small.
Maybe do this.
The problem is that we have the 19 gauge needle, not the access needle, so manipulating.
The cystostome. No, I'm too close to the. I should puncture the duct more, or I should change the position of my scope to go to the tail, because the direction of the wire it's.
So you want to do another puncture, or?
Because.
Oh, that's not bad.
Yes.
Yes, fantastic.
This is good.
Perfect. Oh.
Yes.
Excellent.
Okay.
Excellent.
Now I remove my needle.
So you see that this is typically the case where we have no chance to place a large stent, because the stent that we will place has to make the curve to create and to maintain the fistula. So the stent that we will place will be a 5 French stent to start, and then we will come back again with a longer one. A 5 French 9 centimeter will be.
First the cystostome, hein, Jacques.
Exactly. Okay.
So the principle is to create the fistula and to maintain the fistula open by leaving the stent, and it doesn't matter even the stent blocks. Is that right?
Yes.
No, this is not a problem because the main interest of this technique is to create a fistula between the duct and the stomach. And even if the stent is occluded, the pancreatic juice go around the stent, and to create a permanent fistula between the duct and the stomach.
This is the difference. This is probably one of the reasons why, when we have to drain a cyst which is communicating with the main pancreatic duct, usually we prefer to do a transmural drainage instead of a transpapillary drainage, because the transpapillary drainage is depending on the patency of the stent, and the transmural drainage does not.
Samy, un radio s'il te plaît. Okay, now I use the 6 French cystostom, which is the cystostom from Andoflex. Okay, you see the cystostom arrive now. Okay.
So a very important point here is to avoid to be too curious endoscopically. When you do this kind of thing, you have to keep the endoscope in the same position.
Maybe pure.
It's pure cut 100. It's autocut effect 5. Effect 5 autocut. No, attends. So we are using the RB system. Now we have autocut effect 5. Oh, ça ne va pas. C'est autocut effect 5. 100 watts.
On courbe, ouais.
Prends un autre.
Voilà, là ça va le faire. Là.
Attends, laisse.
Non.
On change.
Attends.
Mets une plaque, Samy, mets une plaque.
Plaque.
Une plaque,
So we are just changing the generator to go back to the very simple RB to be sure that we are in pure cut. If you want to enter, you see that there is no coagulation when you enter. Oh, what about that? Of course, at this time we must be extremely careful and have a check on the floor, not to have a loop.
X-ray.
Okay, because your position is not the same anymore, and the risk is to have a loop towards the retroperitoneum. You see your catheter is going in the wrong direction now.
Yeah.
So I think that we must keep the wire in place, and then because then the risk is to go to loop into the retroperitoneum. Non, c'est le contraire.
Je vais me retrouver dans la... Voilà, ça c'est la bonne position.
C'est pas la bonne position radiologique.
Non. Attends, je retire un peu. Je pousse un peu le guide.
Oh, I'm afraid that the wire is going. Yes, you see that the wire is already going a little bit in the retroperitoneum. Or you see the wire. This is the position of the wire which is changed, but you cannot change it, Sonia. So it's maybe the best is to pull back a little bit the system.
Hop, hop, hop. Attends. Voilà. Voilà, ça c'est mieux.
No, we are not going into the duct.
Est-ce qu'on n'est plus dans le péritoine? Tu penses qu'on n'est plus dans le virsung?
C'est vrai, il part comme ça et il devait partir.
Donc tu ne veux pas le rentrer, le repousser le...
So it's good to show that it's a technique which is always a little bit difficult. The good thing is that if we fail, we can again do another puncture. And even if we completely fail when we have a patient with advanced severe chronic pancreatitis, if the patient develops a cyst, then we can drain the cyst in the second step. But this is of course not what we are willing to do. Il y a une dissection là.
Ouais. Et là, je sais pas ce que je peux faire vraiment.
Huh? Okay.
Maybe the solution is to...
Maybe we can pull back a little bit the catheter just to see if we have a chance to go back with the guide wire alone. You see that there is a loop of no. There is a loop of the catheter there, and the loop is not in the good direction. So I think that at this stage I don't know, Mark, but maybe the best would be to try to do another
puncture. Yeah.
You see what happened, Guido?
Yes.
Is that the wire was going straight to the stenosis,
Yes.
and then when pushing, we did some dilaceration aside the duct. And now the tip of the wire is still into the duct, but it's almost impossible to go back in deeply. But we have a good opacification of the duct, and I'm sure that another puncture will be successful. No.
On n'est pas dans le plus dans le virsung là, non? We are not in the duct, no?
No, it's not the duct.
Yes.
Yes, maybe. Oh, it's the duct.
Yes.
Congratulations, Sonia.
On a même très bien, parce qu'on a créé notre truc.
Maybe with the cystostome, I can enter, no?
No, I think that you are still in the false route that has been created.
I think it's better to do another puncture,
I
no?
think so too.
Oui.
Yes, you see, it's almost impossible, even if the tip is in the duct,
No.
it's impossible to straighten this
Allez.
loop. And I think that we must take benefit of the take the opportunity that the duct is still opacified, and
I try to find this is the aorta.
So I think the important message is that it's not only, of course, important to enter the duct, but also the axis that you choose should be the most direct, in order to avoid this kinking.
yes, and not only the access, but also the device that you use to enter the duct. I don't know if we had a problem with the small cystotome here, maybe with a connection with electrocautery. But why we like this cystotome is that you can enter the duct without applying too much pressure. And this is the key, because otherwise I do not understand. I know that there are some of us who are using only a guide wire and then a balloon, but it's in a severe pancreatitis like this, pushing a balloon just after the puncture with the needle, in my experience, is
X-ray?
almost impossible.
Alors, attends. I try to change the position of my scope.
Of course, Mark is trying to puncture a little bit more distally, but of course, more you are going proximally, the smaller is the duct. I usually magnify the picture when the duct is small. It gives me the impression that it's larger.
I think the duct is here, and this is the. On va essayer là, non?
Yeah.
Hein?
Is there any value in when a duct is smaller, using a smaller needle to get a smaller wire initially, just to make sure the 19 gauge compared to that duct is quite large.
But the problem is that if you use a 22 gauge, you can only use a Terumo 020.
Yeah.
And
stiff.
and on a Terumo, the risk of looping is even higher than with a Metro or a Jaguar.
And you're still using the access needle?
No, we are. Mark prefers the 19
regular
gauge
19.
in this
sharper.
In this case, yes. Very difficult.
I personally use very often the needle of the cystotome, or even I put some cutting current on the 19 gauge needle in order to enter more easily inside.
This is the problem here, to pass the.
You want some current on your needle?
But I don't know the direction of my needle, and you see that I'm not in a. I try to be closer as possible of the wall, like this. You can see very well the tip.
Pour une nouvelle 19 gauge. Une nouvelle.
Okay.
If you want, you can have a new
needle, yes.
a new needle, because this one is probably not straight anymore.
Okay, I think.
You think you're in?
That will be better if I go in this direction. Okay. Voilà. Voilà. Okay. Okay. Probably I'm in here, yes.
You think you're in?
Yes.
Sure.
I think. Yes, I'm in.
So Sami, if you can.
But I'm quite in the same position. Maybe not. This position is.
No, you are more proximal.
It's probably much better. Or injecte, parce que je suis dedans sûr.
If there are some questions in the auditorium, don't hesitate to raise your hand, and somebody will come with a microphone.
No. No. Yes. Okay, we are in. Perfect. The problem is that we don't see what we do with the wire, because This is where we would like to have a C-arm because we don't want to turn the patient.
With the C-arm would be a big advantage. You could take the scope off the duct.
Non, non, ça va.
You see that Sami is hiding the air into the stomach to allow to detect the... We will see the wire when it comes out, but I'm not sure that we will be able to follow it when it enters the duct, but hopefully Mark is in a good position.
There's also a contrast leak into the retroperitoneum, or?
Yes.
Oh, yes.
This is probably, but this is as long as we can place a stent, this is not a problem. Of course, the patient had an antibiotic prophylaxis. I'm looking at Pierre Nockerman. Patient had an antibiotic prophylaxis. Huh? Okay, you see that the wire is looping, but we don't know where it loops.
You're not happy?
Not really, no.
No.
As you see.
Tell us why.
Because you see that the wire is looping in
the scope and push this.
I'm not sure that it's looping in the main branch, or maybe yes. But we would like
This
it
is
to
much
go
better for you, this
okay,
position?
that's much better for looking at the wire. So probably Sonia will pull back the wire a little bit, but she is also in trouble because of the
needle.
It's not an access needle, it's a 19 gauge, and we know that with the 19 gauge it's much more difficult to that's much better. Fantastic.
Fantastic, Sonia. Fantastic. Fantastic. Okay,
Excellent.
we do the exchange.
Okay, that's very good. And I think that if we can stay like that, not move...
I don't move. We do un petit peu.
Just
On fait
make sure...
l'échange? Okay.
Just make sure that we are in pure cut.
Attention.
So you see that here, of course, the shape of the pancreatic duct is not easy to follow.
Hey.
And the thing is very important. It's very important to stay in the same position. You don't move at all, huh, Brigitte? You just keep Gardez juste l'endoscope.
It's the position of the scope. Just a moment. I should...
Pull
back.
No, I should...
Encore? Okay. Oh, wait, tout.
This is where a wire with a shorter hydrophilic tip would be advantageous, because it's mostly floppy inside the duct, and if you had the stiff portion inside the duct, you could...
But very often the problem in this position is that
Oui. Maintenant. Maintenant, vous êtes prêts au protocole.
C'est bon.
So,
Okay.
Michael, just to tell you that we hear all your comments with Mariana and Pierre, so you should close your microphone.
Yeah, yes, but it's just to tell you that we suggest to go in to see a few minutes the other room, so we will come back after with you. So Marc and Jacques, we leave you, and Mariana, we hear you. Jacques, yes? We see
Okay,
you?
well, welcome back. Just a few minutes to, maybe 2 minutes to show you that we had to repeat the puncture 2 times, and you see that persistence is the key of success. Also, at one time we have also to decide to stop. So when we decide that we would stop if the last attempt would fail, then Mark again very nicely got the puncture of the duct, and we have been able to place a wire. We have been able to place the cystotome into the duct. And now the next and last challenge, and this can fail also, will be to place a 5 French stent into the duct. But you see that this will be a challenge because of the loop at the entrance of the pancreatic duct, which is typically the problem we have in complete disconnection, which are taking place at the level of the body. So we have chosen a 5 French stent after creating a 6.5 French diathermic fistula between the stomach and the pancreas. So I'm holding the scope just to be sure that it stays in place. Mark is moving really minimally, and now he will try to push the stent. It may take a while, so if you want, you can go back to see Jan Gralnek and this new colonoscope, and we will call you back when we will have placed the stent.
Okay, so we are sure you will succeed your challenge, and then we will come back in a few...
So we have to congratulate Mark, Sonia, and all the team because they have been able to finally place the stent. You see that you should have the fluoroscopic and the endoscopic picture. You see that we have placed 5 French 7 centimeter stent into the pancreatic duct, and you see the nice loop at the entrance of the duct, but the distal flap is inside the duct, so the risk of migration is low. Just to conclude, the next step in this patient will be to recolocate the patient in 1 month, to opacify the tract after removal of the stent, and to place a larger stent which will stay in place for months or years.
Oh, excellent, and congratulations.
Congratulations.